Hello and very good evening to all of you. And thank you so much, Dr. Kamal Sharma, for allowing me to present on this topic of recurrent DVT. Uh, what does it mean? Second episode of deep vein thrombosis in same or the contralateral leg after recovery from the first episode. That is the definition for recurrent DVT. As such, there are no guidelines to manage these cases. But then how do we go about this condition? Clinically, how do we diagnose? On examination, the leg is warm. There is tenderness in the affected leg and the leg is swollen also. This DVT can be provoked or unprovoked. Why do we need to diagnose recurrent DVT? Either we need to give the extended course of oral anticoagulation drugs or maybe the lifelong anticoagulation therapy. But if we miss the recurrent DVT episode, then it has a very high risk of clot progression, thrombus progression, and then further embolization into the pulmonary circulation, and that can give rise to chronic thromboembolic pulmonary hypertension. How do we diagnose in the laboratory? With the help of a D-dimer assay, which is elevated, but it can be elevated in the index episode also, and then it can remain elevated for a longer period of time. With the help of a color Doppler compression ultrasound, that we'll discuss later what is compression ultrasound. Venography, which can be an invasive venography, CT venography, non-invasive one. And if the creatinine is high, then we can go for a MR venography, which is non-nephrotoxic. On ultrasound Doppler, if the vein is affected is new, that means the fresh vein is affected. The diagnosis is straightforward. You look for the compressibility. If the vein is filled with a thrombus, then it is a deep vein thrombosis. But if the vein was earlier also affected, then now if there is a fresh thrombus or it was a residual chronic thrombus which is still there, it is difficult to sometimes diagnose. But then there is a slight increase in the clot diameter of at least 4 millimeters in the serial ultrasound is suggestive of fresh acute on chronic thrombosis. On compression ultrasound Doppler, we look for full compression in the vein. If the vein is not having any thrombus, it is full patent, then it excludes deep vein thrombosis. If it is a non-compressible vein, not affected by DVT in the initial time, then it is suggestive of deep vein thrombosis. We should start the treatment. If it is a non-compressible vein in the prior affected segment, we should go for a D-dimer or clinical correlation. If it is positive, then start treatment or else wait for some time. Now we should look for what are the risk factors for recurrent DVT. As we all know, the bedridden patient is more prone to DVT. So recent surgery, trauma, prolonged bed rest, active cancer, past history of venous thromboembolism. Out of these factors, some are transient risk factors which remain for some times and then they go away. And some are permanent risk factors. If they persist, then you are at lifelong risk of deep vein thrombosis. So out of these surgery, trauma, oral contraceptive pills, prolonged bed rest, hormonal replacement therapy, and pregnancy are the transient risk factors. And some risk factors are persistent, like antiphospholipid antibody syndrome, post-thrombotic syndrome, inflammatory bowel disease, nephrotic syndrome, then myeloproliferative disorders in the form of polycythemia vera, essential thrombocythemia. Then there is a very important entity which we look for in clinical practices, May-Thurner syndrome, or iliac vein compression syndrome, or Cockett syndrome. Then there is an entity called congenital venous malformation. How do we treat a case of recurrent DVT? The anticoagulation is the foremost important thing. We have a lot of drugs available with us. Vitamin K antagonist, factor 10 inhibitors, edoxaban, apixaban, and rivaroxaban. Then direct thrombin inhibitor in the form of dabigatran. And whenever we are giving vitamin K antagonist, warfarin or acetron, we should overlap with low molecular weight heparin or conventional heparin. Once we achieve the INR of 2 to 2.5, then we can think that anticoagulation has been properly achieved. And then endovascular treatment in cases of chronic DVT is a very important role to play. In those cases in which there is a recurrent DVT in the same leg, iliac vein stenosis is the main culprit, and we should treat this iliac vein stenosis with the help of angioplasty, with or without a stent. If there are transient risk factors, we should give anticoagulation for 6 months. But if there are persistent risk factors like antiphospholipid syndrome, May-Turner syndrome, in which the etiology is not correctable or active cancer, we should give anticoagulation for the whole life. Now, there is a subset if the patient has DVT on oral anticoagulation drugs. We should look for hidden cancer. We should look for May-Turner syndrome, iliac vein stenosis. We should look for antiphospholipid syndrome. We should look for paroxysmal nocturnal hemoglobinuria, polycythemia vera, essential thrombocythemia. Then if the patient was on heparin, heparin-induced thrombocytopenia is again a risk factor for that. Now, if there is an iliac vein compression, then we must consider endovascular intervention. And if you have an intravascular ultrasound, that is the best therapy. So this is a pictorial representation. We can see that the red colored right common iliac artery is compressing the blue colored left common iliac vein. And because of this, the vein gets compressed, and distal to the compressed part, there is a stasis. And as for the Werkow's triode, there is predisposition to the thrombosis. And we can see in this young lady who had left leg DVT twice. And in the second picture, we can see that the left common iliac vein is getting compressed in between the bony spine and the right common iliac artery. Now, this is an intravascular ultrasound picture. In the first picture, we can see the iliac vein is little narrowed. And once we do a balloon angioplasty and put a stent, there is a complete circular luminal gain in the left common iliac vein. So there are three types of spurs which can be present. Either it is a lateral compression into the vein, which is called lateral spur, or there is a median partition between the vein, which is called medial spur, or there is a complete membranous occlusion of the iliac vein, or there are multiple channels, which is called diaphragmatic spur in the left common iliac vein. So once we do angioplasty, the artery is opened nicely, and the swelling and the pain in the left iliac vein is resolved. And the patient has to be put on chronic anticoagulation, maybe for the lifelong, with the explained bleeding risk. And if patient is still having recurrent DVT, we should be very judicious in putting inferior vena cava filters to prevent pulmonary thromboembolism. Thank you.